Thank you, Dr. Lalit, for having me here. So the topic which has been given to me that if I have a case of fovea CNPM and if the patient is having ARMD, what I would use. So I am in a debate at this point, although even if this was not the part of debate as well, in my practice, that is my usual practice that I use biosimilars in all my cases. And before I proceed further and defend my case, these are my disclosures. I consult for various biosimilar companies, but for this particular presentation, I do not have any disclosures. So I come with a lot of evidences from various aspects. That's what we have been doing since last 6 to 7 years, trying to understand that what biosimilars are, how we need to unfold various nuances which a lot of people do not know. And that is the range of our publications, which we are trying to convey with the help of our group, which I lead, called International Retina Biosimilar Study Group. I would definitely like to acknowledge all the people across the globe, because biosimilar has started from India, now it is everywhere. You talk about Europe, you talk about UK, you talk about Korea, you talk about Canada, slowly spreading our wings. Now, I'll tell you the reason that why I will use biosimilar. Financial burden. Financial burden, I think this goes without saying in our day-to-day practice. Even if I talk about myself, my father, my mother, with the best of the best patient support program, the innovator Ranibizumab would cost you 60% more than a biosimilar would cost you at this point. Now, what financial burden does? We are talking about the neovascular AMD case. Neovascular AMD case, as soon as you diagnose, this patient needs treatment for life. When you talk to these patients, initially when you counsel these patients, patient would ask how many injections. You need to tell him that until you die, I would treat you. It could be, over the time, last 2-3 years, I might give you 1 injection in 4 months, but still I need to inject whenever the activity comes in. So the treatment burden, you can imagine, it's a non-forgiving disease. DME is a forgiving disease. DME you can wait. Neovascular AMD you cannot wait. So lifelong financial burden, not many can sustain. That's where the financial burden comes in. This is the old stats, 2 to 3 mean injection rate that this country has. I'm sure if you do a survey now, because this stats is quite long back, our injection rate must have gone up. And the credit goes to biosimilar. Next comes to efficacy. Are we compromising anything on the efficacy part? Are we treating with a cheaper medicine and compromising efficacy? No. Because regulatory defines it in a way, you need to show equivalence. And unless you need to show equivalence in terms of efficacy, you would not get approval. So efficacy is proven and is a regulatory requirement. So you need to believe, and I think in the hall, anybody who uses biosimilar would agree with me, they have seen improvement just after 1 injection, 2 injections, the same way the innovator does. Now comes to an important aspect, safety. Regulatory again defines that you need to do the immunological analysis. You need to check AEs in terms of ocular and non-ocular. That's how you get approval. So with the help of regulatory, you make sure that safety is established. See, now I'm in a debate at this point, but I love this field. I love this field, so I do not want to hide anywhere, because safety is something which we all need to discuss in a very, very transparent manner. So let me just unfold the olden talk. This is our paper which we purposefully wrote, that whether safety compromise, which is a perception sometimes about biosimilars, not only in India, across the globe, it's a perception if it is a truth. So let us see whether it's a perception or truth. Let's just, transparently discuss it from the history of Ranibizumab till Ranibizumab. What happened to Ranibizumab when it started in 2015-16? All of us know. Initial couple of batches, you had inflammation. But 2016 onward, there's nothing. All of us use it. Even in ROP in all these cases. Why that happened? You need to understand that. If you look at 2015, India was the first country to introduce Ranibizumab biosimilar, and why those inflammation? India was following, entire world was following the ISO guideline, and ISO guideline was guiding that you can have endotoxin levels of 0.5 EU per ml. But over the time, US FDA has realized that 0.5 might not be a really right thing. You might have some patients showing immunological response with that kind of endotoxin, so they further strengthened it, tightened it, and brought it down to the level of 0.2 EU per ml. And since it has become 0.2 EU per ml, you do not see anything happening in terms of adverse events. Rainy eyes. I'm touching these because these are the sensitive issues, which everybody might have heard, because in this WhatsApp era, news spreads really fast. There was a VRSI safety committee update in the recent past. Unfortunately, I would say, as one of the members of VRSI, we should behave a little more responsibly in terms of handling and initiating the news and overall closing the case. There was one case, both eyes end off. End off is not attributable to directly with the drug. It's a procedural issue across the globe. And one case of inflammation. Now, if you look at the percentage of inflammation overall, 140,000 injection given, IOI percentage is 0.001, it's phenomenally good. Now let's come back, what Innovator has done. Innovator, these are the slides. I am giving you the link downstairs, openly available. You can access this information. FDA. Inflammation with Lucentis right from an RVO 1% up to the 18% in AMD. That's how it started. Can you imagine 18% inflammation tolerance? You can't. This happened with Anchor and Marina. That's what I say. Over the time, endotoxin processes have defined. Now with Lucentis, you don't see any problem. So that's how the evolution has happened. Even if you look at the Lucentis prescribing information, severe inflammation has been reported. So these are biologics. We need to know that there has to be a certain percentage who could respond in such a way. It should not create a negative perception. And let me tell you, if any drug is unsafe, it cannot sustain in the market. There was a biosimilar Ranibizumab, which was brought by Alchem, gave reaction, withdrawn. So you cannot sustain until safety is established. Even an innovative molecule like Biosimilar, such a phenomenal molecule, but we do hesitate to use it as a primary therapy because of these safety concerns. And now the testament of how biosimilar has changed the world, especially in India, thanks to VRSI who has allowed us to do this survey. Now, majority of us have a first-line treatment with biosimilar anti-VEGF. Those days are gone when we used to say on podium that I start my first-line treatment with the Vestin. Now people say I start my first line as biosimilar, Ranibizumab. So this is my last slide on all the podium, whether it's national or international. Whenever it comes to biosimilar, education, because all these molecules, they start with negative perception. And I would say novel assets, innovative molecules, they have more unpredictability like Biosimilar. It was not detected in phase 3. In real world, it detected. So there is more unpredictability compared to the biosimilar if it is a biosimilar of something where the safety and efficacy has already been established. So if you really want to save many lives, and I firmly believe that biosimilars are making difference, and you can save many lives in terms of their vision if you have confidence in biosimilars. Thank you so very much for having me here.